Singh Nair, welcome you on behalf of GE Healthcare to the panel discussion on saving premature babies using technology. We have today with us our moderator, Dr. Sanjay Wazir, and the panelists, Dr. Sanjay Aher, Dr. Jagdish Prasad Sahoo, Dr. Rajath, Athreya, and Dr. Arvind Dahiya. Dr. Sanjay Wazir, being the moderator, will be taking through the profiles of all the panelists in detail. The webinar will cover neurodevelopmental care saving less than 900 gram babies, humidity management in neonates, ELBW babies, humidity settings, managing term baby with MAS and PPHN, and then followed by the question and answer sessions, which you all will be there to ask. I'll just take you through the moderator's profile, Dr. Sanjay Wazir. So we are honored to have with us Dr. Sanjay Wazir. Dr. Sanjay Wazir is currently working as a director of neonatal intensive care units at Cloud9 hospitals in North India. With around 20 years of extensive experience in the field of pediatrics and neonatology, he has been actively involved in teaching and has worked as a visiting faculty across various colleges and forums. He was the chairperson, Central Indian Academy of Pediatrics and Neonatology, Chapter National, involved in running the Fellowship of Neonatology for 1-year program after MD across more than 60 centers across the country. Being an academician, he has over 25 publications under his name, and he is also receiver of medical journals like Neonatology International, Indian Journal of Pediatrics National. Dr. Sanjay's zeal and passion in the field has resulted in inception of Dr. Wazir's Premature Baby Foundation, which aims to create awareness regarding prematurity, advocacy of rights of premature babies, education regarding NICU practices, and helping poor patients. Over to you, Sanjay Wazir, sir, and all the best to all.
Thank you, Mandeep. Thank you for the kind introduction. And now I have a job of introducing the panelists, and I would request the audience to be a little patient because most of them are stalwarts and would have a little longer, biodata. And it's good to have a mix of people who have worked abroad and have come back to India, and of course also people like Dr. Jagdish who have been doing pioneer work in Bhubaneswar. So I'm sure the seminar today or the topic of the discussion today is going to be about the care of the babies in the NICU, about things which we normally do not talk about, like how do you take care of the humidity, what is the temperature how do you manage, and plus like the neurodevelopmental care, developmentally supportive care. These issues now we have moved from an survival to talking about intact survival, and these issues are going to be discussed more and more in the future as well. So to have this discussion, we have 4 great eminent neonatologists and pediatricians. Among that, Dr. Sanjay Aher, he's from Maharashtra, and he has done his DM neonatology, and then he was trained in Canada, Australia, London, and so he's been working in Nasik now and has had 5 years overseas experience in the field of neonatal intensive care. He had a lot of opportunities to practice and settle down in Australia and Canada, but he decided to come back to his hometown Nasik and serve his own people. That's such a great gesture on your behalf. Leaving your comforts and coming back and working in India is such a tough decision that any doctor makes. But hats off to all the people. I'm going to come back, Dr. Dahiya, Dr. Rajath, to have taken that decision. And he's recently successfully treated a neonate with only 550 grams weight. He has been referred, babies, critically premature babies are referred to him all over the North Maharashtra, and is expert in managing extremely low birth weight babies. He's also the official trainer for neonatal resuscitation, CPAP and ventilation workshop for pediatricians. Welcome, Dr. Sanjay. Dr. Jagdish Sahoo, he is the professor and head of neonatology at IMS and SUM Hospital in Bhubaneswar. has almost more than 12 national publications to his credit and has contributed among various other chapters as well. Among the several other awards, the most recent recognitions have been Odisha Health Icon 2019 in the field of neonatology by the Times of India group in 2018. And he was also facilitated at the Odisha State Neocon 2018 as being the important member of scientific committee chairman for the Neocon 2018. He has been a panelist at various national and regional level neonatology conferences. His areas of interest include neonatal pain resuscitation, and more importantly, what the country needs is community neonatology and neonatal nursing training, which is such a good thing to continue because we understand nursing makes almost 80% of the neonatal care, and doctors contribute only 20% of the care in the whole neonatal journey. Next, we have Dr. Rajath Athreya. He is the lead consultant neonatologist at Rainbow Children's Hospital, Marathali, Bangalore. He has 2 decades of experience, and he was awarded the most prestigious Nirmala Kesari Gold Medal Award for a Best Outstanding MD from the state of Karnataka. He pursued his higher training in UK. His decade-long stint in UK included working in top hospitals like King's College Hospital, Guy's, and St. Thomas. He was a consultant neonatology at Lewisham University Hospital. He was also a faculty at the London School of Pediatrics and trainee with the Resuscitation Council, UK. His areas of expertise include transport medicine, neonatal hypoglycemia, therapeutic hypothermia, and of course the new modes of ventilation. He is currently the program director for neonatal fellowships and faculty with the National Board of Examination, and has been running the level 2 NICU in one of the sickest and the most premature babies come to Rainbow for treatment in Bangalore, and he is also lead for the neonatal transport service. His areas of interest in medicine, apart from medicine, include music and writing. I'm sure he's going to sing a song at the end for us. And last but not the least is Dr. Arvind Dahiya. He is a great friend whom I've known for the last almost 7-8 years now. And he also has a similar story of having worked in UK, was living a good life, peaceful life. Then he decided to take revenge on himself, come back to India. And but he is, I'm proud to say that he's like one of the pioneers to even start a critical care and ECMO services in a town like Rohtak, where the ECMO is not even available in most of the centers in the Tier 1 centers also. And he spent 14 years in UK before coming back to India in 2016. Then he was working in an NHS as a consultant intensivist at Nottingham University Hospital. So apart from NICU, his forte is also in PICU, ECMO, air ambulance, and adult ICU. So he's worked in Cambridge, Birmingham, Royal Children's, Royal London, Leicester, and Nottingham. And to his credit, he's established a leading 150-bedded hospital with 60-bedded state-of-art ICU and ECMO program at Kainos Hospital, Rohtak. Welcome, everybody, and thank you for being here. And I'm sure the audience are going to learn many facets of care which are not there in the books and comes from experience that you're going to share. So since the discussion is all about the premature babies and about taking care of the developmentally supportive care aspect of the NICU care, let me start with the questions. And before I go, before we start the chunk of the discussion, may I ask Rajath to clarify some of the terminologies we normally use, like insensible water loss or transepidermal water loss, relative humidity and absolute humidity, and why it's important to even talk about these or keep them in mind while we're dealing with smaller babies less than 1,000 grams. Rajath, your views on that?
Thank you. So when we are talking about water and loss of water, we're talking about 80 to 90, because when you're looking after 26 weeker, 80 to 90% of your baby is actually water, right? a very delicate balance of fluid and water balance is there. Uh, trans Briefly, transepidermal water loss in you and me is about per hour. So that is because we are all very thick skinned, you might want to say. So we have stratum corneum, which is the 16 layers, which is almost, if you have a sheet of paper, it is about 1/4 the thickness. So, but when you have a baby who is less than, the baby has not developed that layer of skin. So the transepidermal water loss is simply 10 times more, like 60 grams to 100 grams per meter square per hour. What does this actually mean? So if this baby were not to be in a, until this point, baby was in a, was swimming in water, right? So there was no the skin. But now the baby has come into a dry and sphere. So the baby can lose up to 140 ml per kg. I'm talking about less than 26 weeks. So by 32 matures. So in essence, transepidermal water loss is a water loss across the epidermis, and the preterm baby is at a huge disadvantage because it has not developed this epidermis, which has a stratum corneum, which will prevent huge amounts of water loss. And if you just think about why this is also important, 1 ml of water which evaporates loses about 500 kilocalories for the baby in terms of heat. So this poor baby will have to somehow use up another so many calories. That is one. So the other thing you asked was insensible water loss. Water loss is something that we usually will find difficult to measure, which is say respiratory membranes like airway and lungs. Stool also has a little bit of water loss. So roughly, this is something that we need to, the only thing we can accurately probably measure is the urine output, correct? The all other water loss is insensible. So if you have a huge amount of transepidermal loss, or if you're using non-humidified gases to ventilate the baby and non-warm gases, then the insensible water loss goes up. What can also make it worse is if you're using a source of radiant warmer without humidity, especially in these babies, where about 40% more insensible water loss the baby incurs. So we've covered 2-3 aspects there. Was there another last part to that question? The humidity part, correct? What is absolute humidity and relative humidity? So humidity is simply the water content in the atmosphere or your surroundings. The absolute humidity will be irrespective of the temperature. So if you have X amount of air plus Y amount of water vapor, so that is what is absolute humidity is. Relative humidity matters. So it matters to meteorologists who predict the weather, who will have to predict precipitation of rain or snowfall or, hailstorm or anything like that. After babies, this is the humidity which is a percentage of the at a given temperature, how saturated it can be. To put it very simply, let us say at 30 degrees Celsius, the atmosphere will allow 8 or 10 chairs water vapor, of which if you say 80%, 8 chairs will be occupied by water vapor. So we will probably discuss a little bit more when we discuss thermoregulation, what type of humidity we need to maintain. Okay. So we've now covered what is transepidermal water loss, why it is important. We've covered what is insensible water loss and how it can be more or less in babies that we are looking after. And we've also talked a little bit about humidity. So yes, Dr. Wazir.
You are mute.
Dr. Wazir is on mute.
Sorry. As I said, like what Dr. Rajath was trying to put across was the smaller the baby, thinner the skin, and a lot of water losses which have to be counted. Maybe we don't need to take care when we're talking of a term baby. For the preterm babies, there could be a lot of water losses from there. Arvind, my question is, how does technology help you maintain the humidity in your NICU, and what relative humidity and temperature do you operate in your NICU? Because this again is a question people they say I set at 24, somebody says 24, 22, and some are to the extent that they're doing it at 37 also because again you're not audible.
Hi, Sanjay. Is that fine now?
Yes, yes.
Hi, Sanjay. So in our neonatal ICU, we maintain humidity and temperature in two ways. Number one, we have a centralized air condition, but with a dehumidification along with the freshly treated air injected along with the time. And we monitor our humidity continuously in the ICU and maintain between 30 to 60 degrees, between 60% of humidity in the neonatal ICU. And if you see that it's going more than our main standard is about 50%, and that how the technology is helping by using high-end HVAC with the freshly treated air system integrated into that helps us a lot to maintain the very clean and proper humidified environment inside the neonatal intensive care. Second thing is that for babies, as we started realizing that the humidification is important, rather than just only having open care warmers, we decided to buy 3 giraffe as well. And that piece of technology made a big difference, especially for the extremely low babies less than 1 kilo. And our nurses and doctors and everyone felt that did make a difference, and a better weight management and the better fluid management. Overall, the satisfaction level of a staff was caring was really high with that. So this piece of technology in two ways: a good HVAC to have a better environment, and then number two, having a thermoneutral and a humidified environment with the help of Omnibet.
So how do you control for the temperature in the NICU? Like what temperature you set?
We set around 24 to 26. More
Okay,
to
so
25 to 27. Something at 25, 27. Some
Yeah,
between
like-
standard will be very down.
Because one of the points which I wanted to emphasize is that like if you keep the temperature too high, and that is I see many a time the practice in some of the NICUs, you actually promote the infections more because your bacteria are going to grow faster if they are at the room temperature, at the body temperature of 37 degree rather than at lower temperature. So even in winters or summers, you need to maintain the temperature somewhere between 22 to 26, as you rightly pointed out, maintaining a temperature, humidity somewhere between 30 to 60%. Now, Dr. Sanjay, and on a practical front, how do you manage humidity in your babies?
Yeah, in our unit also we have giraffe Omnibet for these extremely low birth weight babies. And as far as humidity is concerned, for the babies below 28 weeks gestation, we start incubator humidity at around 80% and continue that for 7 days. After 7 days, we start weaning by 5% every day. And then you can stop incubator humidity when 40% is reached. And another side, for babies more than 28 weeks of gestation, we start at 80% incubator humidity. After 1 day, we can wean humidity by 5% every day till we reach 40%. So you have to start humidity as soon as possible, except while you are doing some emergency procedures like putting some lines. Prolonged humidification should be avoided as it increases the risk of infection, so must be avoided. And always use sterile water to prevent colonization by the bacteria. And you have to empty the water tank when the humidity is not in use. So that's what we do. We start at 80%, and then according to the gestational age of the baby, we start weaning.
So you started at 20, all babies less than 30 weeks or all babies less than 28 weeks?
So preferably all babies below 28 weeks, we put them immediately in the incubator with humidity. For bigger babies, we can, because we don't have that many incubators in our unit, but we prefer for these babies below 28 weeks.
So that's quite sensible, and in fact, resource allocation has to be triaged for sure. And so thankfully, I have four of them, so I don't have to really struggle too much. So anybody less than 29 weeks, we tend to do all of them at least in the first 1 or 2 weeks that do, and you can decrease by 5%, as you rightly said. Uh, Dr. Jagdish, Dr. Sahoo, I just wanted to know, there is one study from MAS which suggested that using a cling wrap around the babies actually would, work as a humidification. I mean, it seems, good for that time. But do you think, it still compares to the incubator? What's your comment on that study? And should you use cling wrap instead of the incubator? Dr. Sahoo.
Yeah, yeah. Actually, the paying capacity of the patients are very low. So we just got a giraffe bed just 6 months back. So we are traditionally still we are using the cling wrap, and we try to maintain the body temperature starting from the delivery room itself by using the polythene wrap around the baby, transporting the baby wrapping, and inside the NICU we prefer to keep the baby who are less than 28 weeks old because only one giraffe in the bed is there. So we try to prefer the sickest and the lowest gestational age baby to a incubator, and rest of the babies we try to manage with a cling wrap only. And this actually another important thing to prevent the insensitive water loss in our unit. What we are using is the application of oil. So cling wrap and oil helps us for preventing those insensitive water loss. And definitely incubator is the best, but we are charging only 1500 rupees for the NICU care for the NICU bed. So with that amount, actually, it is very difficult for us also. So we are using two methods. One is the cling wrap, using the polythene wrap around the baby, and third is using the coconut oil application to prevent the insensitive water loss for these extremely low birth weight babies, less than 28 weeks or less than 1 kg babies in our NICU.
So good. Till this time, at least all the experts have suggested that in smaller babies, if you want to improve the survival, taking care of humidity or preventing insensible water losses is an important part of the care of the baby. If you have a facility for doing an incubator care, you should put the baby in the incubator with a humidity. But in case that's not an option, as Dr. Sahoo was saying, then at least we should look at oiling because that decreases the chances of insensible water losses, and also cling wrap. That's the next best option. And also we should look at other things like the room temperature in of the NICU. We should look at the relative humidity maintained in the NICU, and as Dr. Rajath was saying about making sure that the breathing is through a heated humidified gases. So you always use warm something to warm the respiratory air, because that is one important source of loss of insensible water losses. Thank you so much. And so we now move to the next part. So how do you see, Rajath, the importance of infection control in preterm babies, and using closed incubators, for example, versus radiant warmer versus hybrid models, which can convert into incubator and radiant warmers? Do you think using these would actually reduce the chances of infection?
I think infection is a major risk for all neonatal units wherever we are working. So every effort should be made to reduce the risk of infection, especially hospital-acquired infection or endogenous infections in babies who are extremely vulnerable. So I would, before going to the incubator, I would still feel that the most infectious thing that we have around in neonatal. Okay, so if you keep cleaning them and not going and touching things, will be doing a lot of service. So hand hygiene comes first. And then obviously we will all have our own unit policies, like you have your infection control team, you will have rational use of antibiotics, you will have your care bundles, be it for central lines or ventilation care bundles, and you'll have methods of looking after your hubs and ports. So these are all major sources of infection. how incubators vis-a-vis radiant warmers probably has helped in the sense that we spoke about the vulnerable skin and very very preterm babies. So I think if they're nursed in an incubator with humidity, the skin integrity will be much better. So infection for all our babies. Second thing is it's a great tool for isolation. So suppose you want a baby to be in contact isolation and you do not have the facility of allocating nurses in different rooms. So suppose the baby has an MDR, colonized or infected infection. So incubators come very handy in terms of whether they're good enough for droplet isolation. They probably are much better than if you do not have a negative pressure room and other things. So we have had a few babies where we had to look after in COVID times, and then they would pose risk to other babies. So incubator also provides reasonable droplet isolation. And the reason I like them also is if you barrier between people and the baby, apart from the mother, it kind of ensures minimal handling. Otherwise, you prick and you prod, you handle the baby so many times, you stay away. So as soon one of the things that happens in our golden hour management in extreme preterm is, we set up the incubator, we start the humidity, we receive the lines are done through the portholes. We don't even raise the this thing. You trained our fellows, and then there is a small poster which says minimal handling. So everybody kind of respects that place as a closed space. So it has a role in infection control, but I think you will probably Sanjay touch upon how it was perceived that incubators could be a source of infection if not managed properly. Should I leave that aspect for a little bit later?
Yeah, it's like so you touched upon the point that although there is not enough evidence to compare closed incubator versus radiant warmer in developing country, because sepsis tends to be very not a major problem in Western countries, but in Indian scenario, maybe the experts believe as of now that use of closed incubators may actually reduce the handling of the baby and possibly reduce the chances of infection. Is that what I get from your answer, Rajath?
Yeah, and also extremely small babies, I think skin is much better.
Correct, and the skin, skin is a major portal for infection, and if you can take care of the skin in the first couple of days, you probably have lesser infection. Now, on the same terms, Arvind, I would want to see one of the problems with using humidity control in India is that humidification, or the rainout, which happens. So people are concerned that the use of humidification actually increases the risk of waterborne diseases, especially the Pseudomonas infection would increase, and Burkholderia and all those unusual organisms, Serratia marcescens. So, what's your experience with this?
See, as you mentioned, that risk of infection in Indian setting is fairly high for multiple reasons. Okay, the whole thing, again, before, as Rajath said, it starts from the hands first. Once you sort the hand thing out, that your hand hygiene is good in the unit, and everyone is aware that infection reduction is everyone's duty, not the duty of a technology of one person, then it starts happening. First of all, if you look at the humidification side of it, particularly for Omni Giraffe, our policy is that as we have 3 at our center, if there's one is empty, after every 7 days, we take the baby, shift to one to another and clean it. Maybe it's overkill, but that's what we are doing at the moment. Second, the water which we're using, obviously sterile water at temperature 52 to 58, which again could be bactericidal at this temperature and may reduce the infection. Third, when the baby is taken out after the care of 1 week or 2 weeks, whatever the protocol is, according to that, we thoroughly clean, spend 2 hours, devotedly 2 hours, and everyone has to stick to the protocol of cleaning when one person supervising and 2 person doing, rather than one person cutting the corners. So these three ways we maintain the strict infection control protocol as long as the omni bed goes. But in general, in the hospital as well, from humidity side of it, we have ensured one thing, that all hospital water is RO treated water. We take samples from the surface very regularly to keep a tab on the infection around. We sometimes also check, I don't know how scientific, to air spores, samples from air, and check is there something growing in there. And all these things have come to the point that now for many months we don't get positive cultures into our unit, despite of significant humidified incubators and maintaining up to 50 degree of humidity in neonatal intensive care.
Yeah. Dr. Sanjay, there's a question from the audience. So in between, I will also be taking the question from the audience. Is that any need for sending routine cultures from the humidification chambers? And do air purifiers are of any value inside the NICU? They're talking about one with a plasma circulation, and not specifically the HEPA filters, but they're talking about the routine air purifiers. Do they have value in prevention of infection, and is there a role for routine culture from humidification chamber?
So the infection part and other things are already covered. According to American Academy of Pediatrics, the NICU should have a minimum of 6 air changes per hour. And if it is an isolation room, it should be around 12 air changes per hour. And if relative humidity is very low, that is below 40%, then it increases the risk of bacterial as well as viral infection. And I don't think there is need to send the swabs from the incubator. That is what you are asking, right?
And not in the humidification chamber of the omnibed.
But if you are using sterile water every time, and if you are keeping it empty when the humidity is not on, I don't think it is necessary. But as Dr. Dahiya said, that if you are using RO treated water for everything in the NICU, for the water which we are using in the incubator also, which is RO treated, then I don't think it is necessary.
Yeah, so these kind of practices they are born out of fear rather than evidence. So there's no need for sending routine. Of course, if you have a breakdown of an epidemic in your unit, then you would need to do surveillance from other sources also to check where is the source of infection. But as a routine policy, no. And similarly, air purifiers only reduce the PM 2.5 and PM 10 particles. They do not have an effect on the bacterial, even with so-called the plasma ion technology. So there's no point in keeping air purifiers inside the NICU. In fact, throwing of air from across is certainly not advisable. Dr. Sahoo, one of the questions is like, how frequently do you apply coconut oil for your premature babies? And you talked about cling wrap on the warmer, but somebody is asking cling wrap around the plastic sheet around the baby. Should you continue using it after delivery? I get the question right. So once you get the baby into NICU, you put the baby onto the plastic wrap. Should you continue doing that?
Yeah, just immediately after the baby is delivered, we just wrap that food grade polythene wrap around the baby. But once the baby is shifted to the NICU, we just put the baby under the radiant warmer. And if it is less than 28 weeks, definitely in the incubator, then immediately that plastic wrap is removed, and we used to cover the radiant warmer bassinets through the cling wrap. And we used to continue this cling wrap for 2 weeks at least. And regarding the oil application, we have a policy every day morning shift and in the evening shift 2 times we apply oil. So that we routinely do for all babies who are delivered less than 32 weeks.
So that's I hope that answers the question, that once we have brought the baby from the delivery room to the NICU, you have to remove the body fitting plastic sheet. You can put a cling wrap on the incubator itself. So, Dr. Sahoo, in a closed incubator, how do you use the spin mode or the air mode, and how does one decide about the same?
Yeah, there are 2 types of mode in the incubator. Either it is a skin mode or the servo control mode, where the actually machine, the microprocessor decides about the baby's measures the baby temperature, and it gives the heater output depending upon the baby temperature. The baby temperature has to be in between 36.5 to 37.5. But in case of air mode, here the temperature setting depends upon the gestational age of the baby and the postnatal age of the baby. And then we have to decide on the thermoneutral zone of the temperature. The charts are available. So roughly for a 30-week-old baby, we set it at 34 degrees centigrade. But always use that thermoneutral temperature chart for setting the temperature when you use a air mode. But conventionally, after the servo control mode is available, we use servo control mode in the incubator for the temperature setting, not the air mode at present, because it helps us. It doesn't help constant monitoring of the baby. The temperature monitoring can be avoided when you use a continuous servo control monitoring.
Great. So, Rajath, one of the important things that we have been discussing now of late is that how well the baby is after 2 years or 5 years in case of a premature. We were talking about survival at one time. Now, when I talk to people in India, many times, the decision is always wrong. So they always assign 28 weeks as saying that it's like I have a 25 weeks because the decision is not available, and because they have an IVR baby, so they always talk in terms of low weight. So, in your experience, both in UK and now here in Spain, so what do you think is the developmental outcome in Indian scenario, which is possible? Because in Indian scenario, one of the other problems is that the sicker babies do not survive, and it's the survival of the fittest, and then you tend to say, oh, our survivals are better than even UK and US also.
Yes, so I think we really do not know as a country where we are in terms of both survival and survival without disability. We can all quote our own data, but I think it is quite heterogeneous. So if we're just looking at overall neurodisability, it is below 28 weeks. It is simply even Western data post steroid era. If you just take cerebral palsy as a hardcore disability, it is 150 times more compared to other term baby. 15% in less than 28 weeks is 0.1% in a term baby. Correct. So it is quite high. And then this is only a tip of the iceberg. We have cognitive problems. We have autism disorder. We have central visual issues, hearing issues. Disability burden that we probably should be seeing, because more and more of these babies are surviving, is not becoming very obvious, Sanjay. Maybe because we are not having that kind of a detailed neurodevelopmental follow-up in all settings. It may not be possible. But having said that, the survival, what I've seen working in the UK, I was there when Epicure 2 we were recruiting for, which we quote quite often for less than 26. So in centers like ours and US, we probably see similar or slightly better outcomes in terms of numbers. And disability in our experience is more than 50% in extremely very, very small babies, less than 26 weeks. So maybe this is because we have the luxury of intervening at many points in this baby's journey, right from the antenatal, be it steroids, magnesium sulfate, delivery room management, infection control, lung protective strategies and things like that. Simple things like not allowing hypocarbia, using a self-weaning mode of ventilation, for example, will avoid cerebral ischemia quite a lot, because we used to focus so much on IVA and GMH and meningitis. So those we are seeing less and less, right? Because we are much better at looking after things, and most of the instances we would have had antenatal steroids. But see that a lot of non-cystic PVL changes and non-motor disabilities becoming apparent if we really look. So that is the experience that I relate here. Was the question also, the voice broke up a little bit, Sanjay, was the question also is what we can do to kind of mitigate?
No.
No.
because the point we'll come to that as a part of a discussion also. What
What was your question, or was it a little bit off track? So I missed the last part of the question. Yeah.
Forget about like we will be covering that part in the subsequent discussion also. So we just wanted to have what is the view like, and one of the important things which came out from the discussion with Dr. Rajath was that we do not have a robust way to find out what is happening to our children. We have no reason to believe that our children are faring better than the people outside of the West, and we have all the reasons to look after the development after discharge from the NICU, and to look after that they merge into the society seamlessly like all other term babies. So, Arvind, what is the developmentally supportive care of preterm babies, and what's the importance? Mute again, please.
Sorry. As Dr. Rajath just said, that the disability incidence is fairly high in extremely low birth babies. So it's very important that we start paying attention to this aspect of intact survival with minimal disability possible. Especially as one, we obviously see the major disability, but many minor disabilities goes unnoticed. And there are many things we can do to prevent that. First of all, what we are realizing now and doing it as well, that treating family as part of treating unit, not as someone who is intruding our space. So we make them partners in the care. Mother's room is next to the neonatal ICU, and encourage them to be there most of the time so that they are part of it. And promoting KMCA as well as being standard of care now. Secondly, we maintain a kind of a neonate cap inspired program in our intensive care, where all the staffs are being made aware of this program first. You can have whatever program you like, but if the staff is not aware and they don't understand the importance of it, they won't participate. First of all, we ensured, and we do ensure, that our staff understands that the importance of this developmental impact of these little intervention like reduction of noise. So they are being trained not to speak loudly, control their noise inside the unit, don't drag the chairs, make noises. And secondly, few small things like attend the alarm immediately and put the lowest possible noise levels. Do not disturb the babies in terms of when they are sleeping, the protected sleeping time, do the procedure at a certain time, minimal handling. In incubators, use the cover to minimize light on this baby so that they can sleep and be comfortable there. And since we have done that, actually our nurses gave us a feedback that the babies are very, very comfortable. And that's now consolidated the idea of these little intervention much more. And they're now being very well established as a part of developmental support with a possible better outcome in future.
So very rightly said, like, we tend to often ignore the noise, the light, and the stresses of the NICU. And if you have to be in that noise all the time, you will get stressed yourself, and the child who has to spend 2 months there all the time, I'm sure that must be doing enough to damage or cause stress to the child, and the stress at that level of developing brain would probably have long-term implications also. Now, Dr. Sanjay, I just wanted to ask you, one of the major determinants of outcome in very small babies, like 24, 26-week babies, is the prevention of IVH. And has your practice changed after you had the giraffe or an omnibed in terms of do you take it to delivery room? Because one problem which arises that you have a separate cot in the delivery room, then you transfer the baby, pick it up and put it again. So there are enough blood volume fluctuations at that point of time in babies. So how do you do in your level, or yours is only a outbound unit?
Definitely, when babies are in giraffe, they are less disturbed and they are not handled frequently and can get exposed to noise. So this all decreases the incidence of intraventricular hemorrhage. And they have our unit is a standalone level 3 NICU. So we don't have that privilege to resuscitate neonates in giraffe in the obstetric unit. So we go there, we resuscitate the babies in plastic wrap, and then we transfer these babies in embrace bags or transport incubator to the NICU, and then we put the babies in giraffe incubator. So ours is not like a mother and child unit, so that's why we don't have that facility in obstetric practice.
So maybe Arvind, can you share like what do? You take the giraffe into the delivery room?
We actually do take the giraffe extremely low birth babies to the delivery room, and we take the babies straight there and bring that giraffe to our intensive care and the continuity of care without breaking the thermal protection between both neonates.
Okay, so that's very important. Practice change. We also have incorporated that small babies do not need to shift from one place to other and just lifting them. And for which again, I would come to Dr. Sahoo and say, how frequently do you weigh your babies in your unit? And smaller babies, do you do only the blood gas, only the sodium, or do you just forget about doing the blood, weight in the first couple of days? And how do you do that? Because moving the babies for the weight in the radiant warmer is quite a stress for the small babies. Dr. Sao is there? Okay, maybe, I think come back. I can't see the list. Anyway, maybe Dr. Sanjay, I wanted to ask you, what is your unit protocol for developmental screening and intervention if required? And which scales do you use for routine monitoring? And who does the screening in your unit? And, is there a person who has special training or how does it work out in your unit?
So we use F.N.P.M, that is Infant Neurological International Battery for the Development, Training and Intervention for Neonates and Infants. So this you can use from birth till 18 months, F.N.P.M, and it checks for 5 factors: spasticity, vestibular function, head and trunk, French angles, and legs. So it's an observational scale. You get such type of sheets where you can just chart it on the angles and everything. So it is available with the physiotherapist which visit our unit. So you just have to chart that, and for this we have to use baby's corrected gestational age, not the chronological age. And it can be done either by pediatrician or physiotherapist or occupational therapist or even by a nurse. It doesn't need any special training to administer the scale, and the equipments we require is only pen, this scoring scale, and goniometer to check various angles. And we must calculate, as I said, corrected age of the infant, which is very important, and tally the corrected age with that score. So this can be done by anyone, F.N.P. Scoring.
Okay, so and so Dr. Sawal, we were trying to ask you, one of the privileges we have is like we weigh the babies in the same giraffe omnibet. So how do you manage weighing, or do you actually weigh your babies at all if required in the radiant formers, especially the smaller babies? And how do you do the fluid management based on weight, based on sodium, urine osmolality? What is that you use?
No, for the baby who are managed in the radiant warmer, we usually look at the urine output, blood sodium, everyday weight to manage the baby. And every day every day morning in the morning session, the sister used to do the hello.
Will listening.
I am audible. Okay, so every day morning the sisters used to weigh that and we'll do the fluid chatting according to that. But when we use a incubator, particularly the babies who are less than 28 weeks, actually we have a policy of checking the weight daily twice, and lesser the gestational age, we check it more frequently, the weight. And depending the weight of the baby and urine output and sodium, these are the 3 things what we decide regarding the fluid management for these babies.
Very good. Although, my personal experience, I would share may not be evidence based, but we have done away with weighing because the smaller babies in the humidity care or the omnibird do not lose as much as fluid. So, disturbing the baby, lifting them would actually make them prone to slightly more, IVH and other stabilities, including the infections. So we tend to obviously offset that, but and we follow only the serum sodiums and the urine output for sake of not disturbing the child. And there is a question which is said, we have a giraffe incubator. We set servo temperature at 36.5. At times, to our horror, baby's rectal temperature shoots to 37.2. So what's the explanation?
So you need to check at that point of time whether actually the probe is properly placed or not. If the probe is missed, actually, the automatically the temperature will be very high. It will be overheated. So I think that will be the suggestion.
Yeah. So most of the times, which I have also seen, if the child is lying, prone, and the probe is on the ventral surface and it is between the skin, so then it ends up causing more hyperthermia. So one of the things that you need to do is just put the probe on the backside. So some of the questions may not be related to the discussion, but a brief about how LED phototherapy works for jaundice in newborn. It is like any other phototherapy with a higher irradiance, and you probably can use it and it works by converting the bilirubin inside the blood into photoisomers. The role of vitamin A in preventing BPD, very limited. This based on one large study which changed from incidence from 62 to 56%. So you may, and that too had to be given intramuscular. So you could use it. There's no evidence is for using, but the benefit is very marginal. Do probiotics help in babies less than 34 weeks in NEC? And if so, which one? Maybe any one of you can answer. And I wanted Jagdish because Dr. Panigri's study came from Katak only, so on nature. So maybe you can answer that one.
Yeah, so the probiotics has been proven to be reducing the risk of sepsis in the previous studies by Dr. Panigrai, and also it reduces the risk of NEC. But to tell you the truth, we have not started using as a routine for prevention of NEC for the premature babies in our NICU. But regarding from the studies, so the lactobacillus GG group and the bifidobacterium group has been studied as a is the choice of the probiotics what they are using in different centers. In some centers also in India, we know it's a mixture of 2 to 3 probiotics they are using. Particularly one center is using Darolac as a probiotic for prevention of NEC. But in our NICU, we have not started probiotics as a routine for prevention of NEC in our for the newborn babies.
So that I hope that answers your question, whoever had asked that. So the point is that the consensus on probiotics is still not on whether to use it in all or in select group of babies. So, hello.
Hello.
Yeah. Okay. So one of the Rajath, I wanted to ask you the last part of the discussion we wanted to have on babies with MAS and PPHN because they are also sensitive to various stimuli. So to begin with, I want to ask you, in a case with MAS and PPHN, what modes of ventilation do you prefer while ventilating such babies? Rajath. I think we lost them somewhere. So, Arvind, I want to come back to you and I'll come back to Rajath a little later. Often it is quoted that MAS may have an incidence of early between 20 to 40%. Now, this was an old data, but in your practice with gentle ventilation, what ventilation strategy we use in practice with MAS? Because we don't see such a huge air leaks any further now.
Yep. I mean, if I say in last 4 years, we have seen, I count maybe one patient of air leak with a meconium aspiration syndrome was very sick, maybe one, I can't remember this, very recently we had one. So with a gentler ventilation, the incidence of air leak has gone down significantly. In that sense, if you think that if we are in terms of ventilation, we try not to use too high a PEEP. We try to optimize the PEEP, looking at the variance factor. Normally, we tend to prefer somewhere between 5 to 8 max and try not to overinflate too much in these babies when there's air trapping is in the first place. Second thing which we are doing is gentle ventilation of 5 to 7, 5 to 6 ml per kg of tidal volume, sometimes even lower than that slightly if we are not too much bothered about rest of the parameters. Generally around 4 to 6, more would 5. If I see that a rate, we try to go slightly faster rate, but with this, looking at the graph, the flow time graph, and we make sure that the TE time is sufficient enough for the flow to come to the baseline. Thus, we are keeping a close eye on the flow time graph. On top of it, rate we tend to between 40 to 60, and PO2 targets are around somewhere around 70 to 80. We keep PO2, PCO2 in the range 35 to 40. Try not to be too aggressive in that sense, but if they're developing the PPHN, then the strategy will change a bit, which the rest of the speaker will touch upon. In general, the dictum is gentler ventilation. If your mean air pressures are going too high, think about high frequency. But again and again, one important fact, be gentle with these lungs and try not to overinflate too much with the slightly faster rates.
So very important point now you made is that we need to look at other aspects of technology, like for example, flow volume curves, and following to decide what is the right amount of TE time that you need to give him for smaller, what is the right amount of TI time that you need to set up, and the monitoring of the volume and not to overinflate. So that's a valid point that we need to discuss and see and talk to our residents about that, and based on that, the outcomes in MAS and PPHN have dramatically have changed. Now, Rajath, while you're not there, so in the case of MAS and PPHN, what modes of ventilation do you really go for? High frequency in all cases initially, or you start with the conventional ventilation, and which exactly mode you start with what rationale?
So I don't think there's a single answer, but the preferred mode is HFO. I'm thinking that you're thinking of really severe ones, not just the ones where a little bit of oxygenation difficulty is there. So if I'm running into the problems with oxygenation, I'm definitely going to oscillate, because I can recruit more in a much easier way, and then and also probably plug into nitric if required. So that is the thing. Otherwise, we end up needing to use very high pressures to recruit. And suppose, God forbid, we have an air leak, then we lose the game. So that is the advantage of oscillating.
Okay, but for milder cases, do you use CPAP or even patient-triggered ventilation? Maybe Dr. Sahoo can take it up. Rajath's connection seems to be
So when
Recording is on.
Hello, am I audible, sir? Yeah. Hello.
Go on.
Yeah, whenever baby comes to the NICU with a respiratory distress, we assess the baby as per the respiratory distress score, how severe it is. So depending upon the respiratory distress score, we decide, and depending upon the oxygen requirement, how much F.I.N requirement is. If the baby is requiring more than 40% oxygen, or the baby has a respiratory distress score of more than 7, then we directly go for intubation. Otherwise, we usually try to keep the baby on a non-invasive respiratory mode if the respiratory distress score is around 3 to 5, and then take a X-ray. And if the X-ray and the target is, the X-ray should show 5 to 6 anterior ribs clearly, 6 to 8 anterior ribs clearly. It should not be hyperinflated. The pressures in CPAP, what we start with in a case of MAS, we start with around 4 to 5 with a F.I.N of 50%, and depending upon the targeted saturation, what pre-ductal targeted saturation of 90 to 95%, we titrate on the saturation on the F.I.N requirement. And similarly, depending upon the retraction and the oxygen requirement, we decide whether the baby will be continued on CPAP or NIV. But suppose there is deterioration on CPAP and there is gradually increasing requirement of F.I.N, then we try to put the baby, we intubate the baby and go for conventional ventilation. Again, because the high frequency, we have only one high frequency ventilator. So we used to connect first with the conventional ventilation and try to manage the baby with a conventional ventilation with PEEP of around 4 to 6 and pressures of around 18 to 20 depending upon the requirement, and we'll go up with a target oxygenation PO2 of 50 to 70, PCO2 of around 50 to 55 millimeter of mercury with a pH of more than 7. With this target, we manage the conventional ventilation. But suppose the baby is requiring very high PIP, more than 25, then in our setup, what we feel, we used to open up the lung by giving a surfactant, and then after that, we try to put the baby on high frequency ventilation. So this is our strategy from CPAP to intubation to surfactant, then high frequency ventilation at the last stage.
So like what he's saying, 2/3 of the babies of MAS can be managed with CPAP alone. Dr.
Yes,
Dr. Aher, I would want your views on the role of surfactant, because this often gets talked about. Do you use surfactant in all cases or selected cases with MAS?
Not all cases, but definitely we use surfactant in babies where you have X-ray picture which is suggestive of moderate to severe meconium aspiration, and baby is not maintaining saturation even on high frequency ventilation before going to nitric oxide and further management. Yes, definitely if it is in the early hours, maybe between 6 to 8 hours before, like up from delivery to 8 hours, we can definitely think of giving surfactant.
So which surfactant and what dose do you use is the question people have asked.
We all have natural surfactants, so you have 3 products available in the market. Any of them you can use. So it is 100 milligram per kg for that baby. So generally we prefer Curosurf because the volume of that surfactant is less. So it doesn't cause obstruction in the endotracheal tube while using surfactant. Because other surfactant, the volume is quite big for the weight, because it is according to the weight, either 4 ml or 5 ml per kg. So I prefer using Curosurf in this baby.
So one of the problems with MAS is the concomitant PPHN. So do you often do an echo in all babies with PPHN, Dr. Sahoo? And what do you think, like, what's your protocol about how to and when to screen? Or only the symptomatic babies who have pulse oxygenation difference between upper and the lower limb?
No, for the meconium aspiration syndrome babies, most of the time it is associated with the asphyxia. And if the baby has a evidence of poor perfusion, definitely we used to go for echocardiography. And in a baby with a MAS, and if there is oxygenation requirement is very high, more than 50%, so definitely we will go for echocardiography, because there is definitely some amount of pulmonary hypertension component is there that is requiring more pressures to open up the lungs. So we definitely go for echocardiography routinely if the F.I.N requirement is more than 40% or 50%.
Dr. Aher, since you have the widest experience, about the nitric oxide, people also say your comments of sildenafil versus nitric oxide, and do you stick to that oxygenation index of 25, or you started a little earlier?
So before we start nitric oxide or sildenafil, we have to confirm our diagnosis of PPHN by echocardiography. The cardinal findings include abnormal right ventricular dilatation, then leftward deviation of interventricular septum, then tricuspid regurgitation, and right to left shunting at the level of foramen ovale. So these are the signs which we see on 2D echo or echocardiography, and then we decide whether to go for nitric oxide. Nitric oxide is not available in all centers, but nitric oxide is a gold standard in management of PPHN. And as you say, oxygenation index, yes, While we are on optimal settings on the ventilator, either it is conventional or high frequency with 100% FiO2 we are using. And if the oxygenation index is more than 20, we go for inhaled nitric oxide. We start at 20 parts per million. And after 8 to 12 hours, once the baby's FiO2 requirements are below 60%, we start weaning nitric oxide. And we follow the protocol. And as far as sildenafil is concerned, yes, if it is resource limited settings, IV sildenafil can be used. The loading dose is around 0.1 milligram per kg for 30 minutes, and then you give 0.03 milligram per kg per hour. You can use that till the baby stabilize, and after that you can use oral dose. There are few studies where they have shown that oral sildenafil is also very effective when you don't have inhaled nitric oxide or IV sildenafil available. So yes, definitely there is role of sildenafil, but again, inhaled nitric oxide is a gold standard.
So I would tend to agree, like, although people, Rajath wants to come in for some comment.
I often tell, because we retrieve a lot of babies who might end up on nitric. So because we have nitric, our use of nitric on the babies who we actually retrieve is only 50%, because there are a lot of other things you can do before you switch the nitric on. And one of the most important things is to anticipate. Very typically, just for the benefit of audience, Sanjay, if I may, is to anticipate the spiraling down of PPHN in babies who were really okay, but started needing a little bit of oxygen 2-3 hours into their life after having gone through meconium stained liquor. So these are babies who are very deceptive, and you should never trust them. So those babies should receive reasonably aggressive, non-invasive support, oxygen support, whatever it is. You need to be a little bit 1 or 2 steps ahead of these babies. And typically what we see in the babies we receive is those babies are left to gradually go down for about 8 hours, either with a mother or in a nursery where lower oxygen saturations were accepted for a while, and then they reach a point of inflection where severe PPHN is set in. Okay, so lucky or those babies who display all the full-blown signs right from the beginning, I think they cry out for help and they get it. But these deceptive babies are the ones. But those babies, what we do, we even before we oscillate, we sedate them, we recruit quite, we using slightly higher pressures. We sometimes use surfactant. We use slightly longer eye times. We give 100% oxygen. And by the time we do all those things, we often see that the OI has already started coming down, because people naturally were quite scared in peripheries to use higher pressures and other things. But because we have the backup of everything else, we can be a little bit more adventurous. And we use nitric only in half the cases where we actually retrieved the baby for nitric. So that is the experience. But then nitric works, if you have the facility, nitric works much better. So what the message I wanted to go across is about anticipation. So even babies coming to a center with nitric, half of them do not need it. We could have managed it without that. So anticipating, being a little bit more aggressive in respiratory support actually will get you out. And everything else that can make the PPHN worse, you need to avoid, like pain or like acidosis, too little hemoglobin if there was abruption, polycythemia, anything else that can tilt the balance will definitely tilt the balance for this patient.
Rajath, in the same question, audience, somebody from the audience has asked the question: which sedation you use in babies with MAS and PPHN? And I'm sure another question which is going to come, whether you use muscle relaxant or not.
Muscle relaxant extremely rarely. If I've gone out to retrieve a baby, then I have a very difficult journey, and I cannot risk extubation and things like that. But muscle relaxant mostly no, so I'm just going to park it. But I use opiates. So just using something like midazolam is a sedative but not an analgesia. It won't work in the way you actually want it to work. So we use opiates. There is hardly much to choose between morphine and fentanyl. but one has to remember about giving a loading dose. So either of those opiates should act well only if you give a loading dose, because you need to semi-saturate the opiate receptors for it to start acting. Fentanyl has the advantage of working in few minutes. The onset of action is a little bit faster. Then when we want to stop it, it is a little bit easier to stop because morphine actually accumulates a little bit longer. But whichever one you have access to, suppose you do not have access to either of those, then probably you could use benzodiazepine for a very short period of time until you reach a place where this thing. So I have spoken to a lot of units, and I think anesthetists are allowed to prescribe opiates in certain hospitals. So you might, go that way. But it is very, very safe to use opiates in these babies. Muscle relaxation only for a very short period of time if I have to really recruit lungs and risk too much risk of too much of extubation. Risk of extubation is too high if I'm moving the baby.
So, Arvind, one of the persons has asked a question that we do not have a high frequency ventilation. Your views on using pressure control ventilation with pressure support mode in MAS with adequate PEEP and PI from the curves and loop.
Sorry, can you repeat the question? I just missed some few lines. It's a bad connection.
Yeah, is it they don't have HFO, so pressure controlled ventilation. So I'm not too sure if anybody nowadays uses purely a pressure controlled ventilation. So everybody uses the patient triggered ventilation as mode. Whether you use SMV with pressure support. So what I think he wants to ask is probably a combination of single mode like a patient triggered ventilation or assist control, or a combination of SIMV with pressure support. Which would you prefer in MAS? Pressure control ventilation, not to be never sedate the child so much, or you take use the muscle relaxant as Dr. Rajath was just saying, enough to control the ventilation all by yourself.
Yep, that's pretty much we are doing the same thing. When if you don't have a high frequency, you don't have. If a child needs one, then rather than bashing the lungs at the center, they should transfer somewhere where they have.
Yeah, that's a nice quote. Bashing the lungs. Good one. Okay. So that's, here we go. And one question I have for you, Dr. Sahoo. So how do you reduce the stimulus of babies? Because these babies with MAS and PPH are extremely sensitive to environmental stimuli, and when there is such a baby who arrives in the NICU, there is a lot of commotion from nurses around, the doctors starting yelling and other things. So how do you actually protect your babies from that stimulus? And if you have an incubator, would you like to use an incubator in a baby with MAS and PPH?
Actually, it will be better to put the baby, if an incubator is available, put a baby in an incubator. That is the best thing to decrease the stimuli. But in our place, because the incubator is not available most of the time, so what we used to do is we used to cover the eyes with a gauze pad. We used to plug the ears with a ear plug or a cotton bud, and we just try to sedate the baby with fentanyl infusion, continuous fentanyl infusion at around 2 to 4 microgram per kg per hour. So that is the way how we sedate these babies. And most of the time, these babies do well with fentanyl infusion. If the baby is still having some problem, then we add on midazolam, SOS, short-term SOS along with fentanyl infusion. That's what we use. But definitely, if the baby we have the facility of an incubator, better to put the baby on an incubator and put on the central lines, atrial lines. That is the luxury if you have it, and you can definitely use it.
So I think the point here made is that to make sure that environmental stimulus do not worsen the outcome of babies with PPHN. Dr. Aher, last few questions that I have. If you do not have an echocardiogram and you suspect PPHN, do you think the role what is the role of difference in the pre and the post ductal SpO2?
Definitely, if you don't have 2D echo available or echocardiogram, then initial evaluation should be include thorough history and physical examination, simultaneous measurement of preductal and postductal saturations, chest X-ray, and arterial blood gases. So, if there is hypoxemia which is disproportionate to severity of parenchymal disease on the chest radiograph, you should suspect idiopathic PPHN or cyanotic heart disease. If preductal and postductal oxygen saturation and PaO2 measurements are used to differentiate PPHN from structural heart disease, if the saturation difference is greater than 5 to 10%, or PaO2 difference of more than 10 to 20 millimeters of mercury between right upper limb and lower limb are considered significant. So definitely, if you don't have echo facility, then preductal, postductal saturation as well as PaO2 on arterial blood gas is very useful.
Okay. The only caveat here would be that if the shunt is at the atrial level, probably you'll not see the difference. Only if the PDA is the shunting mechanism, then you'll probably see the PD and postductal difference. Somebody's asked the role of IV thiamine in PPHN. I have not heard of it, so I would probably not Oh,
can I make
Rajath again?
Thiamine, Sanjay?
Yeah, please go ahead.
So probably you haven't, because people don't eat polished rice in Noida or Uttar Pradesh.
Yeah.
But we are seeing quite a lot of very young infants who have gone into severe PPHN and they have dramatically responded to thiamine. So these are very young infants. So actually we are thinking that maternal thiamine levels also probably are low, and one or two anecdotal instances where there was no setup for PPHN in terms of meconium aspiration or a syndromic diagnosis, but day 2, day 3 babies have gone into PPHN, newborn babies. So Andhra, Telangana region more than other places. So those babies we are planning to actually do a study. Even if we get 5 of those things, 5 of those babies, we wanted to see the response to thiamine. So there is a thiamine responsive PPHN we see in some parts of southern India.
But that's
But
awesome.
as of now, nobody is reported in the newborn period, but it is not hard to imagine that it can happen.
Okay, that's interesting because I didn't know about this thing at all. And somebody has asked a question about I know it's quite expensive. Could you elaborate the use of milrinone in PPHN? Truly speaking, there is no published data on suggesting that milrinone actually is going to be having a significant effect on PPHN. There are only 2 small case series from one center only. They suggested that you use milrinone in babies with PPHN without compromising the systemic blood pressure. So we did not routinely recommend the use of it, but if you have to use it, one of the important things that you need to consider is that not to use a loading dose because it tends to cause hypotension. So if you use it so don't use a loading dose if you consider using that. What day of life you can start coconut oil application in ELBW babies is the question. I mean, it's not about the day; it's about the stability of the child. Wouldn't be baby so. The one question is, how do you give phototherapy when the baby is in the giraffe omnibed? From the top. Anyone has and you can even use Billy Blackett in addition. I think we answered, Arpita, we've kind of answered most of the questions, unless there are any further questions. I will request the panelists to make last take-home message from each of the panelists about the care of the babies and especially the developmentally supportive care. Dr. Arvind, to start in a clockwise fashion and then.
Yes, Sanjay. My last One thing which when I came back to India and started this neonatal ICU, my biggest struggle to start with was very unique. How low we expect from our neonatal ICUs. One of the obstetrician, she asked me, would you be able to save a 2 kg baby for us? I was stunned. The first take-home message for obstetrician, pediatrician in the small town especially, if you're given the good care, most preterm baby do survive. It's all about sticking to the good care, expect a lot from yourself, do not downgrade yourself, do invest in technology, human resource. We normally call 3M. One is men and women, no disrespect to women. Second M, we stand for methods, put the right protocols in place. And the third thing, machines. Do buy appropriate machines, do buy good technology, whatever required. And if you don't have that technology, please do not treat that kind of a baby, which happens unfortunately for whatever reasons. That's my take home from the last 4 years since I'm back to my homeland.
Dr. Sanjay?
I think only survival of a extremely low birth weight baby is not important, but the intact survival of this baby is very, very important. So we have to make sure that these babies go home neurologically intact, their eyes are normal, their ears are normal. So those all screening has to be done appropriately. All babies should have their hearing screening before going home, ROP screening if it's extremely preterm baby at 3 weeks, then other babies at 4 weeks of age. And nowadays we have this laser therapy available everywhere. As Dr. Arvind said, that we have to use the technology and we have to send the babies to the centers where they have the technology. Sometimes babies don't get nitric oxide and they die. So I request everyone, if you don't have nitric oxide facility and that baby needs that facility, that baby should go to that center. So I think the technology use is very important. As I said, intact survival, we should aim for intact survival of these babies. Thank you.
Dr. Rajath?
My point, I mean, excellent points covered by other panelists. So what I would want to say is the man or the woman behind the machine is probably as important as the machine itself. So when I worked in the UK, we had the luxury, we would have a clinical scientific expert on the unit, we would have a biomedical engineer, we would have a nurse specialist. So I did not know the front end of the CPAP machine to its back end, to be completely honest. We would just look at the baby and then troubleshoot. But it was a very steep learning curve. And within 3 months, because I was there at the beginning of the setting up of the unit, right from infusion pumps to nitric oxide, I had to relearn the whole thing, and it was really, really useful. So I think what in neonatology we need to remember that there are stakeholders. So the consultant or the neonatologist running or looking after the baby is just one of the stakeholders. So there is your nursing staff, there is your support staff, and there are parents. So and obstetricians, as you said, one is to very in a positive way to parents and the obstetric team, but also to very well train your nursing staff and your junior cadre that they will be using technology to the baby's benefit. Okay, so I was stunned to see that a baby was left in an incubator on skin mode, a 23-weeker in one of the hospitals I had visited here in India, where the probe had come off and nobody had noticed, and the next day the baby was was like Lace crisp, potato chips, because sodium had gone to 170 and baby had lost all its. So the technology is quite dangerous if it is not used with the power of training and constant monitoring and troubleshooting. So training and assimilating technology becomes very, very important.
And Dr. Sahoo, the last word from you.
Yeah, what I personally feel is, along with the resources, the training of the nursing personnel is the most important thing, because they are the backbone of the NICU. And second most important part is the monitoring. What we miss most as a consultant, we most of the time just tell the staff nurses and go. So more the time we spend inside the NICU looking at the babies, looking at the clinical monitor of the babies can help us. And in our centers, we unfortunately we don't have units with nitric oxide facility, or the transport team is not well developed so that we can refer one baby to a higher center. So we have to manage those babies in our own. But what helps us most is the clinical monitoring. We sit by the bedside of the baby and just clinically monitor the baby and manage. So that helps us most. So the monitoring is one of the most important part along with the nursing training, what I call.
So, thank you, panelists, and it was wonderful having all of you here and share your views and your expertise on the subject. And in the end, I would want to wrap up and saying that you would probably make a lot of wonders to the care and also the intact survival of the babies when you combine the clinical monitoring and using the technology to this optimum. And one should never look at a return on investment of some of these things. Like you should probably, because the return on investment may not be from business point of view, but from your social responsibility, your national cause, and giving an intact child to the family is much more rewarding than just looking at what is the cost involved in treating such a child. And if, as some of the panelists said, if you do not have a facility, just be kind enough to offer the child to be shifted to a unit where they would probably be safe in a much better way. Thank you everyone for your time and your evenings, and thank you audience for being there. Good wrap up now, with thanks to all.
Thank you.
Thank you.